Okay, so I was just going to hit upon a little bit of the diabetes in pregnancy and sort of what we need to think about in these patients who we see just for diabetes and how we need to address them. So I based that off the Endocrine Society guidelines from 13. You can go to the next slide. So preconception counseling should cover things like your insulin therapy, your folic acid, ocular care, renal function, blood pressure management, vascular risk assessment, lipid management, thyroid function, their weight, and their gestational diabetes status. Next slide. So we already know that maternal hyperglycemia in the first few weeks of pregnancy can increase the risk of fetal malformations, spontaneous abortions, and perinatal mortality. And the anomaly risk is quite concerning because if they have an A1C of up to 10.4%, they actually increase their risk up to 5%, and anything over 10.4%, the risk climbs to 10.9%. So higher maternal glucose may lead to an increased frequency of birth weight above the 90th percentile, primary C-sections, neonatal hypoglycemia, elevated cord C-peptide levels, increased risk for preeclampsia, preterm delivery, shoulder dystocia, birth injury, hyperbilirubinemia, and neonatal intensive care admissions. And then, of course, babies born to mothers with gestational diabetes are at an increased risk of later developing obesity and type 2 diabetes. Next slide. So anybody in your clinic, any woman who's of childbearing age and considering pregnancy, you should always think about, if this is something I want to pursue, and just counseling them, even if they're really not thinking about it right now, it could be something in the future. So the key points you want to hit at that visit, or any visit for that matter, would be pregnancy should be planned, and they need to have good control prior to conceiving. You also want to assess any morbidities and optimize those prior to them trying to get pregnant. Discontinue any unsafe meds. You want to start them on folic acid, talk about smoking cessation, and tell them that yes, it is a time commitment when you do this. And of course, we would like them to notify one of us or somebody if they become pregnant. Next slide. Keep getting this little thing on my screen. Sorry, guys. Can you see that? No? Okay. So to go through some of those, for glycemic control, you want to strive to achieve as close as possible and safely without undue hypoglycemia. So people already treated on insulin and seeking to conceive, you want to try to get them on multiple daily doses of insulin or a continuous insulin pump rather than using split dosed or premixed insulins. You would like to make the changes well in advance before they withdraw any sort of contraception. You can use Lispro and Aspart, that's Novolog and Humalog, in preference to your regular insulin. And then if the patient is successfully using long-acting analogs like Levemir or Lantus, which is Detamir and Glargine, preconceptionally, you want to continue these before and then during the pregnancy. Both are associated with lower rates of nocturnal hypoglycemia and are widely used in pregnancy with good safety evidence. Next slide. So what is approved in pregnancy so far? We know that Novolog, Humalog, Regular, Levemir, and NPH are the FDA approved ones. The ones that are not include the Apidra, which is your rapid acting like Novolog or Humalog, Lantus, Glyburide or Metformin. A lot of patients still use Lantus during pregnancy, and it has good safety data, but they're just not technically approved by FDA. And that's the same thing that goes for Glyburide or Metformin. And most women with type 2 requiring blood glucose lowering medications are treated with insulin in anticipation of the pregnancy and then during the pregnancy. Next slide. So renal function, we want to make sure you have everything sort of in order before they want to get pregnant. And you want to check baseline labs such as your microalbumin to creatinine ratio, your creatinine, your GFR. If it's an issue, you want to make sure they see a nephrologist prior to trying to conceive, because we know that the risk of worsening renal function during pregnancy goes way up. And then you want to, of course, monitor during the pregnancy. Renal dysfunction in type 1s can be associated with an increased risk of adverse maternal and fetal outcomes. And the more severe the dysfunction prior to pregnancy is a worry because it can progress and you may not be able to reverse it. And also, just kind of as an aside, I mean, at this point, you know, even though we're endocrine, I personally try to get them into the high risk OB people prior to trying to conceive. So you can address any of these topics, but, you know, there is also that high risk department that you could refer them to. As far as their eye care, retinopathy also can worsen before pregnancy, so you want an eye exam pre-conception. If there's anything recommended in terms of therapy, you want to have that done prior to and stabilized before they try to get pregnant. Okay, I thought we were going to add something. And then if they do have established retinopathy, they should see a specialist every trimester and then within 3 months of delivery and then as needed after that. If there is no retinopathy known prior to, you want to have them have an assessment soon after conception and then periodically. And even up to a year after pregnancy, their retinopathy can advance. So you want to make sure you think about risk reduction and regular follow-up. People who have the pre-existing hypertension, poorly controlled blood pressure during the pregnancy, preeclampsia, and poor glycemic control can actually increase that risk. Next slide. Folic acid, they recommend about 3 months prior to withdrawing any sort of contraception to reduce the risk of neural tube defects, and they would recommend about 5 milligrams a day. For blood pressure, ideally less than 130 over 80 preconception. And then, of course, you want to stop those medications that aren't approved, which is your ACE and ARBs. But they do have some people who continue on them just on exceptional cases, like say they have severe renal disease. And if they didn't really know when they were going to try to get pregnant, you could continue those until they do become pregnant. If they're on them, they call you up, they say, I'm pregnant, then just stop them at that point, obviously. And most are proven to be teratogenic in the 2nd and 3rd trimesters. And the alternatives that you could use include the methyldopa, labetalol, diltiazem, clonidine, and prazosin. For lipid management, they don't normally recommend statin, fenofibrates, niacin in those who are attempting to conceive. And then really the bile acid resins may be used, but seldom warranted. Next slide. Vascular risk, you want to screen for cardiovascular disease and risk assessment prior to. If they have any established CAD, of course, you want to make sure you look at the severity of it, treatment if it's needed, and then counseling provided for the potential risks to the woman and the fetus. And of course, I would probably refer them back to the cardiologist or make sure they clear them for pregnancy. Thyroid function, about 44% of type 1s can actually have a risk of developing hypothyroidism. Type 1, they usually get a TSH and a TPO antibody at the prior to pregnancy to kind of assess their risk for that. And then, of course, you definitely want to treat that to goal prior to getting pregnant because, one, it can cause them to have difficulties becoming pregnant. It can make their periods irregular, and we know there's an increased risk of miscarriage and impaired fetal brain development in patients who are undertreated. So weight, if they're overweight, we want them to try to lose weight prior to pregnancy, so counseling on that's important. Next slide. I think that's it. Is that slide 9? 9 or 10, Caitlin?
Yes, that's slide 10 there.
I wanted to just kind of stop there, and then next visit in a couple of weeks, we're going to go over the last end of the recommendations and guidelines.
Yep, that's perfect. All right, guys, do you guys have any questions about this? Any follow-up? I know a couple of people came in late, and you all are muted, so make sure you unmute yourself. Oh, I can't hear you, Dr. Pollywall.
Hello?
Yeah.
Yeah. Yeah, I joined midway, so I'm not sure whether it has already been answered or not. Now, for type 2 the patient who are not sure whether they're gonna be pregnant in near future or not. Apart from putting on insulin, as of right now, are we considering any other oral medication that we can put on?
Some safety would be your glyburide or your metformin. But as far as any of the new agents, I'm not aware of any of those being used yet. And I think maybe Actos sometimes, Melissa? Sometimes. But sometimes Actos, like in your PCOS patients, we would use that, or I guess any type 2 diabetic, you could try Actos, but as far as approval in pregnancy, I don't know of any others.
So these medicines, metformin, glyburide, Actos, we can put them on, and as soon as they know they are pregnant, they should discontinue, they should continue, how it should work.
So I would kind of defer to the oncologist on that, or the OB doctor, but they recommend that if they're type 2, you should try to institute insulin prior to trying. Now, I know what you're saying is if you don't really know how long it's going to take, what I'm seeing is that some people do stay on metformin and glyburide, but I haven't seen any others. It's not approved, but they have shown some safety data. It's sort of like Lantus as well. It's not approved, but people use it. So once they see, we do the preconception, kind of talk to them a little bit. I usually refer back to the high risk OB and let them talk to them as well. And I basically refer it to them. And typically they don't usually see us during pregnancy, although we are getting more cases than we used to. But I would say if this, there's been relatively safe data on them taking those, I probably wouldn't stop them unless they were progressively getting more insulin resistant and not well controlled, then I would insulin.
That's kind of what they talk about, is if they're doing well, you don't want to disrupt that. So the continuation is benefits versus risk, and they feel the benefits of keeping a better A1C. But once you start to fall and develop, as the pregnancy goes on, they have higher sugars no matter what. And so they probably are not going to survive on those medications, because as the pregnancy increases, especially in the first trimester to early second, you need more and more insulin. You develop a resistance and sugars go higher. So they probably aren't going to maintain on that. So then once they're already over, they're not maintaining, then you would be switching them to insulin, and then you would just discontinue those meds because you can basically control it in insulin. So you kind of wait for their sugars to dictate the switch over. That makes sense?
Thank you.
Renee, thank you so much for the didactic. Everybody, we have plenty of time today, so if you guys have questions about anything, or if you need to discuss a case impromptu that you didn't submit, that's totally fine. I wanted to leave the time open for you guys. Anything?
Is it possible you can discuss how to differentiate between type 2 and type 1 diabetes based on the testing for antibodies?
Well, there are a lot of antibodies out there I think we don't even know about, but the main ones we use is the GAD65, the glutamic acid decarboxylase 65 antibody. We have the islet cell antibody, and then the newer one we've been using is called zinc cotransporter 8. So, you know, those are the ones we would use to look at type 1 diabetics.
So when you try to order the test, you try to order all these 4 antibodies.
I usually use the last one as a later type test. Like if I've done the first, like I usually always order a GAD 65 and an islet cell, and if those come back negative and I'm sort of still kind of worried that they could possibly be a type 1, then I would do the zinc co-transporter, because it does take a little longer. I mean, it's probably 4 weeks worth at least to get that result back. So then that one, I don't always order that first, but that is one that we've started doing more often.
Okay, thank you.
All right, guys. Well, our next session, I believe, is on the 26th, I want to say. Anyway, I'll send that out to you in the reminder. But I'm going to go ahead and send out the slides that we covered today, not the slides for next time. So if you guys have any questions about it, please feel free to reach out so that, you know, we can get those questions answered and everything. I don't want to end it 30 minutes early if somebody has a question, but... All right. I'll see you guys all in 2 weeks. Thank you again, Renee.